a circular algorithm if people learn off the pictures, and then there's the regular algorithm, which is just a lot of words and boxes. So I put both of them on there. So initially, the most important thing with ACLS, just like BLS, is alert the ambulance. So alert for somebody to get help. Call 911 while you're starting CPR. So initially, you're going to just do your BLS. Obviously, making sure patient's unconscious, not alert, not responsive, checking a pulse, and checking for respirations. Okay. Most of the places that you're going to be at now will have a defibrillator, so also when you yell at somebody to call 911, yell at somebody else to go find a defibrillator, AED. If you are obviously in the ER, which is what we're learning now in emergency medicine, you have everything right there on the crash cart and a huge monitor to put them on. The ambulance crew will give you a report just like anything else. They may be in the middle of a code. The most important things for you to know is what was reported of the patient's status before they went down. How long have they been down? Okay, so just like in a stroke, a code is really important as far as timing, because we need to know how long has it been that they've possibly had a hypoxic event, so that you know the physiology of how their body has responded. How long have they been without oxygen? Are they acidotic? Are they going to respond to the medications that we start cramming in of the IV? So we've already learned when they hit the door, if you're not in an area that has paramedics, they may not be intubated. So obviously airway, number one, get them intubated. Number two, somebody's going to be on their chest, so they're going to be doing chest compressions and bagging them while you're getting the intubation materials together. Your crash cart's going to be open. You're going to have all of it right there in the different drawers. So you're going to have that in the skills lab to where you're going to practice intubating, and then Dr. Lovelace actually teaches and makes it a little bit of a game, and so then you'll start timing and having different scenarios of like your materials getting wet and your hands being all bloody. So obviously we're not going to use real blood, but he gobbles KY all over you and still has you like time and see how stressful he can make it for you. Shaking the bed like if you were in the back of an ambulance, those kinds of things, which is going to be rare. But still, you're in a nervous situation. You may be shaking like this, regardless if you're in an ambulance or not. So, your team is all going to work together, and I know that for test purposes, we still have to say, what is your primary steps? What is the first thing that you've got to do? And so we go through those ABCs, airway, making sure that you are getting ready to intubate. Somebody is currently bagging them, and circulation is going at the same time, because oxygen does no good if it's not circulating through your body. So you've got to have somebody on the chest doing chest compressions, somebody bagging them doing oxygen. So you're going to learn just the little bit piece that you put in their mouth to open their airway, because obviously they're completely unconscious, and you've not intubated them and secured their airway with an ET tube yet. So that little plastic piece has to be in there so that you can get good bagging. The things that you're going to learn in experience in time is the resistance of bagging somebody. So if you're having a lot of resistance, that could clue you into there may be an upper airway obstruction. Maybe they choked, maybe something's in there blocking it. If it's rigid in their lungs, they may have already been hyperventilated so much to where they've got so much resistance to you bagging them. Or they have gone into acute respiratory distress to where they've got inflammation and those airways are clamped down and it's causing resistance. The other thing is that, once you do intubate them, making sure that you didn't intubate into the esophagus and you're pushing a lot of air into their stomach. that's going to give you some resistance in bagging too. So making sure that as soon as you throw that ET tube down, you're auscultating and checking placement. You don't have time yet to do a chest x-ray for placement. You've got to do that quick check with the stethoscope. So you're listening for lung sounds bilaterally both sides. What's the most common error in somebody being intubated as far as if you have breath sounds only on the right and not on the left? You're in the right main bronchostem, which is the bigger one, and the more linear. The other one kind of curves off quite a bit. So what do you do to correct that? Back the tube out. Very good. So you guys have already had all of this. I'm not in every lecture, so I don't know, but I was assuming, and I don't like to assume. So now we've got the ET tube in. We've got a good airway. We've confirmed it. Not only you've confirmed with auscultation of the stethoscope, but then you put the calorimeter, purple, yellow pH pad on there to confirm. And then once that is done, then you blow up the tube to secure it and tape it down. Don't tape it down and blow that up until you confirm that it's in good placement. Then you can move on, and whoever's bagging can take over, and the chest compression. So you've got somebody recording, somebody watching everything, and usually you are going to be the lead, and you're going to be the one watching everything once you've intubated. So once you've intubated, you kind of step back, and then you just direct everything and watch. And you're watching the monitor the whole time. You're giving direction for the medications, and you're going through your head what caused this, if you don't immediately know. Okay. So, if they haven't already gotten IV access, 2 large bore IVs, 1 on each side. If they've clamped down and their circulatory system is resistant to being able to access it peripherally, then you're going to have to do a central line. That is, again, your job to do. And now, you do it ultrasound guided, so it's a little easier. I did it blindly. It was all skill, knowing your anatomy, knowing where you're going, and just getting it in and getting it done. But ultrasound guided, obviously, is the standard of care now. If you've got access to it, you must utilize it for liability reasons. Okay. There's no reason not to use it. So that's the other reason why in Capstone that we kind of introduced that ultrasound. I also had towards the end of the ER, Julie, which is Professor Rourke's sister, as an ultrasonographer. She's going to come in and give you really a good basic lowdown of the machine and how to utilize it and looking at the ultrasound. All right, so oxygen, intubation, chest compressions, bagging, slap the pads on front and back. That's all going to be done immediately when they get to your bay. So like when they're taking that patient from the gurney, from the ambulance crew onto your bed, that's the perfect time to slap those pads on them. And you're going to have somebody that's already got the pads and ready and is in position to do that. So just knowing in your head everything that needs to be done, you're watching all of that occur and getting your stuff together, which you should be very familiar with your crash cart, knowing where everything is at. When you got that call coming in with the ambulance crew, you know what their skill set is. If they're just basics, you know I need to intubate as soon as they get the door. So I've already got my crash cart open. I've got all of my stuff out. I already know if it's a male or a female, and they've already told me their patient's weight size. So then you already know what size tube and all of that you're going to use, okay? So see how everything kind of works together. That's why they call those things in, obviously. They've already told you how long they've been doing CPR, what medications they've given, if any, whether or not they've gotten IV access. So you've already got that knowledge. So steps again, ABCs. Airway, breathing as far as bagging, circulation, chest compressions, getting the pads on them. And then once they're intubated, you're starting through that algorithm. As soon as the pads are on, you're looking at the monitor. First thing you're going to do, obviously, what rhythm are they in? What can we do, and what's the protocol? Do they have a pulse with that monitor reading? That's the other big thing. Anytime you see the monitor reading, and you already identified the arrhythmia or the rhythm, check pulse. Obviously, you're going to check pulse when they're not doing chest compressions. So I know that seems like common sense, but we're all nervous when it happens, and I've seen it done. So make sure that you're stop chest compressions, then check pulse. All right. The algorithm for cardiac arrest is so much easier now. Epinephrine, imiodarone, those are your main two drugs. Epi initially. Anytime you do a drug, again, things are going so fast and your body feels like you're running a marathon, or not a marathon, a sprint, that you have got to slow down and think and watch. Because once you push a medication and you follow it with a flush so that you can make sure that it's gone through the line completely. Because those meds, you're given an amphetamine is how you would order it. It's just a small amount. And that IV Heplock may hold some in there. So you've got to flush it immediately. And the nurses will have all of this knowledge already. They are already going to be well seasoned and applying new codes for you. It will be okay for you to say, I don't know what to do next, and ask for help. You're going to do it. It's just going to happen. You're not going to do it, and you're going to freeze up. Your brain's going to stop. So ask for help, and then watch and learn, and think of all the simple things that you could say, making sure that you're watching them push that, and that they've flushed it so that it's cleared out of the line and they're getting the full dose of that medicine. And then you're restarting chest compressions, because if you're not on their chest and circulating it, then that medicine is staying right there and not doing its job. That's why it's every 3 to 5 minutes, and 3 to 5 minutes is an eternity during a code. So make sure that you're double checking with your recorder. Some facilities, I've never had the advantage of this, have a big digital clock that's counting. And they actually have a code clock that's separate, that somebody actually pushes the button and it'll start counting. And so when it's getting close to 3 minutes or 5 minutes, then another drug is pushed, and then they push the button again, that starts the time over again. Kind of cool to have all of that set up, but I've never had that experience. So I was constantly, how long has it been since my last epidose? What are we looking at the monitor here? To me, they're not responding. What do we need to do next? So your rhythm, of course, can only be checked when you're stopping the chest compressions again, but you don't want to stop for a long period of time. So you're doing epinephrine, an amp of epi every 3 to 5 minutes times 3. And so there's 3 to 5 minutes apart of each of those. And then circulating through, continuing CPR immediately after the drug is pushed. You're monitoring and watching the CPR quality so that you've got a full chest compression, that they're not just barely eat. That's not going to give any circulation as well. Be professional again. Just say, looks like you're getting a little tired. I don't think that we're getting the full depth of compressions there. Let's switch. Make sure you've got 2 people that can switch back and forth. Or you can even ask somebody, put your hand down, find a femoral pulse. This is why we teach you where that femoral pulse is. If you can't feel even a faint femoral pulse during chest compressions, then you're not perfusing and you're not circulating it good enough. Okay? And then once you're watching all of that and continuously watching the monitor, stop CPR, look at the monitor, see if they've responded and gotten back into a rhythm. If not, resume CPR, go on with the next medication, okay? So that's the basics on any code, but we're talking about cardiac arrest. So somebody that literally collapses in the mall. And they'll tell you whether or not they've shocked them or what rhythm that they've had. And then, of course, you'll see that coming on board, too. So, I can't read that, and I didn't bring my glasses, so I have to stand back here for a minute. Know your statistics on how far the depth is for chest compressions for an adult and a pediatric. You're going to get PALS later on. Just a brief intro on PALS. Just so that you know that there's a difference in the chest compression and a little bit of variation on your compressions versus ventilation. When you've got multiple people on there, you're really not counting. The person doing chest compressions is counting, and then the person doing the bag is trying to coordinate that, as well as reporting to you how much resistance they're getting with the bagging. If there was a submersion in water, or somebody that has gotten a lot of pulmonary edema, such as CHF, you may have a lot of resistance there as well with the bagging. So that will help you to know, again, when you go through what is my etiology of what caused this cardiac arrest, then telling you those things is important for you to help decipher what's going on in the patient's situation. CPR quality, you've learned this in BLS, just making sure that you're getting good depth, good chest recoil, minimizing the length of the interruption of your compressions to watch the monitor, avoid excessive ventilation. So you're watching also your PCO2 or your SpO2 on the monitor. Your compression rate, as far as your person doing that, needs to rotate every 2 minutes. Sometimes you're going to have somebody go, no, I'm okay. Still have them rotate every 2 minutes so that they don't get tired. Sometimes your adrenaline's going so much that you don't realize that it's hurting your back until after it's all over. So again, take care of your team. Say, you know, I know you feel like you're doing okay. Let's go ahead and rotate. You're the lead. Be professional about it, and they'll respect you for that. And if you put it in that manner, if I've got to take care of my team so that we can take care of our patients, then they will respect you for that. The wave capnography, again, is on the monitor as well, so you'll be watching that. But once you've got your confirmation, that should be, everything should coincide. Drug therapy, again, only 2 drugs with cardiac arrest, so epi and then amiodarone. We've already talked about the advanced airway. 10 breaths a minute, which is essentially just as fast as you can. I mean, that bag is big enough to where it kind of regulates and keeps you from really being able to hyperventilate. You need to have that bag fully inflate before you squeeze it again. If you're squeezing it before it fully inflates, then you're doing it too fast. If you're ever on the bag, that's just a good rule of thumb so that you don't get nervous. Because again, you're going so fast in your mind, things tend to go faster. Everybody's watching each other. So once you have a good rhythm show back up, the first thing that you want to do is get a pulse, get a blood pressure. Document that. And then you're going to continuously do that. So your nurse is going to set the machine where the blood pressure cut's going to go off, like every minute, so that you can watch that. That way you know if even though they've got a return spontaneous circulation because they've got a good rhythm, yet their blood pressure is not high enough to sustain, you may need to start pressors. Okay. So that's what you're analyzing once you've got return of spontaneous circulation, which is also known as ROSC. If you ever hear somebody say that, that's the acronym, ROSC. There's a whole algorithm that's on this PowerPoint as well, as far as what to go through once you have gotten back to a normal rhythm. All right. Again, cardiac arrest most of the time is caused by pulseless VTAC or VFib. So if you've got paramedics on board or somebody that they had an AED at the scene, they may have already been shocked. So that's information that will be in their report, but they need to be telling you that, and they will be letting you know. So that way you know what the shock energy was, how many times they've already shocked them, what all has been done. All right. And then if they're still not responding, which there's only the 2 drugs now that you're rotating back and forth, epi and amiodarone. Let's say it's gone on 20, 30 minutes and they've not had a return of spontaneous circulation. Really, within 3 doses of your epi and your first dose of amiodarone, if they've not responded, you need to start thinking and start asking more questions to the ambulance crew. And if they don't have the answers, then you're also going to have somebody already dedicated that can communicate with the family or people that will come with the patient. So, you know, are they history of drug user? Do they have any allergies? What medications are they on? What were they doing, or have they been sick? You know, have they had a pneumonia on top of their CHF that has caused an exacerbation, and they just had a severe hypoxic event? Have they just recently had surgery to where maybe they threw a PE? So you're going through what we call the H's and T's. You're trying to figure out if there's a reversible cause, because until you figure that out and try it, you don't know how to reverse it by treating it accordingly. So, know your H's and T's. That will be on your test as far as the ACLS test Saturday. Okay? And what that will look like is they will give you a patient scenario in writing, just like our questions, and they'll say, what's the first line of treatment for it? Well, you've got to know what the cause was before you know how to fix it. Okay. So those are your H's being hypovolemia. So you're going to use suppressors and fluids. Hypoxia, which again we've intubated, so that should start correcting itself. But if they've got severe hypoxia, then they are also got an acidosis more than likely, respiratory-wise, going on. Looking at the EKG or even your monitor rhythm, you'll be able to see if you've got really peaked T waves to help you know whether or not you've got hypertonia possibilities. Another thing would be their list of medications. If they're a CHF patient and you just had a huge change in their diuretics and they weren't given a potassium supplement, things like that. Hypothermia obviously would be where they were found. If they were out hunting and buddy brought him in because he fell out of the tree unconscious, or while they were walking to the truck, he clutched his chest and fell down. That happens. Those are common things because the cold air exacerbates their already pre-existing cardiac disease. Tension pneumo, what are you going to be looking for on that? Right. Visually, you're going to see the shifted tracheal deviation, is what we call that. That's how it be worded. Your chest x-ray obviously is going to have shifted, but you're not going to have a chest x-ray yet. Once you get ROSC and they're stable a little bit, then you can order your chest x-ray. And you should always order a chest x-ray in the ER, portable of course. They're not going to go down to radiology, they're going to be standing for confirmation of tooth placement and everything else. Central line, if you've got that put in as well before they go to the floor, so that you've got confirmation of what you did in the ER before that patient was moved, that everything was good. Cardiac tamponade, what's that going to look like?
PEA.
PEA, is that what you said?
Yeah.
On monitor?
Maybe, I don't know.
Is it at pulsus alternates on an EKG?
Oh, yeah.
Or Corsage could even present colors too. Toxins, so not only if they're a drug user as far as toxins, but have they been talking about suicide? Did they possibly overdose on something? If it's a kid, were they out in the shop with dad, and dad was working on the car underneath the car, not really watching the 4-year-old, 5-year-old? This could very well happen in children. I always think, oh, I know that tons of generations grew up that way, and how strict of a mom should I be? But I can't go outside because he's going to be busy doing what he's doing. But then, you know, you can cuddle them too much, but then accidents happen so fast. So that was after our toxicology lecture. I went home, went to the shop, and made sure that the antifreeze and that the windshield wiper fluid was on the top shelf. So, because they go over their leg, their trampoline is in the shop because it's a little warmer, and I just send them out there with that, and I'm thinking, no, I'm a bad mom. No, I just know all the bad things that can happen. All right, PE, course 2. If they've recently had a surgery, you need to know those types of past medical history immediately. Be thinking of all of these things, or even a coronary emboli if they've recently had an echo and they've known that they had a dilated ventricle or cardiomyopathy, or atrial fib, new onset of atrial fib. So not only does that clot possibly be thrown into the coronary arteries and go to the brain, which is more common than anything else to present as a stroke, but it could chunk off and go into the coronary arteries as well and present. Not as common, but it could. So again, you've got to think of all of these things to be able to know how to reverse it. All right. Here's the other algorithm. So you're in the mall, patient goes down, you are first on the scene, you're yelling at somebody to get the AED, you're yelling at somebody to call 911, you're starting CPR with chest compressions. Usually the AED box will also have a mouth protector for whoever's going to be doing CPR. It won't always have a bag, but it'll protect. And there's always those pocket protectors if you guys are ever in an area where you think that, I don't know, they sell them, they're really, really small and they can go in the kitchen. I don't carry one. Very rare. In my 20 years, I have not come across this yet in public. We're more than likely going to come up on a car accident where somebody has to be, you know, stabilized in that beforehand. So, obviously, the AED is the first thing that you're going to be able to tell if they're in VTAC or VFib. But you're going to do your CPR, your basic stuff. You're checking to make sure they're unconscious, checking their pulse, checking to see if they're breathing, and then if not, we're starting chest compressions first, doing the breathing, doing, depending on that, if you have one person or two, depends on the number of compressions to air. So it's 30 to 2, correct? Right. And then, of course, you've got to know which rhythms are shockable and which ones aren't. You will have to know that, always. This just goes through the complete algorithm. Again, CPR for 2 minutes while you're getting IV access, getting all of that stuff going on. Obviously, if you're in the mall and you're not going to have IV access, that will come when the ambulance crew arrives. If you're in the mall, they're not going to have any drugs with that AED. So you're essentially going to have nothing other than doing your basic. That's why we teach both, and you have to be certified in both BLS and ACLS. And the Good Samaritan law protects you as a provider. So nobody can sue you if something goes wrong out in the field. More than likely, the odds are against you. You don't have all your equipment. All right. So same thing that I just went over, just a different format. Here is the Ross slide. So essentially, once they have return of spontaneous circulation, the big light bulb that came on to me whenever I was learning this initially in ER is, what was the last drug that we used on them that converted them into a normal rhythm? And if you don't remember, it's okay, ask your reporter, what's the last drug I just gave them? Because now they're in normal rhythm. We've got return of spontaneous circulation. Stop the chest compressions because you don't want to alter that and make them go out of it. You're still going to be watching the oxygen saturation. If they're not able to maintain, you may have to supplement them a little bit. But you switch that over to a mask, or the actual bag still has oxygen. It's hooked up to oxygen all the time. So it's okay to leave that over and just have it high. Whatever that medication was is the drip that you will set and maintain them to keep them from going out of that normal rhythm for a while, and that's what they will go to the floor on. If their EKG obviously looked like they were having a major MI, then you're going to be on the phone with the cardiologist, flying them out if you're ruled to get them to a heart cath. If you're in the city, you've already had the cardiologist on the phone. They've probably already been down before you even get to this point and taken over. But they're going to take them straight to the cath lab. The advanced critical care is where you will have all of your medications. So these are the drips that you would send them up on. If they converted with Epi, you're going to do the IV Epi drip. If it was amiodarone, you're going to do the amiodarone drip. It's not on here. What? I'll have to get that to you because that's a possibility as well. So I did hear Dr. Latassi talking about when she gave her local anesthetic and lidocaine, talked about that. Lidocaine has the potential for decreasing the irritability of the heart and keeping it from going into another arrhythmia. So we used to do lidocaine trips, or at least bolus them before we put them on a regular trip. That is not in the protocol anymore. So I'm telling you that because of the fact that you're going to be practicing with preceptors and physicians that have learned in different generations and been taught different things, as well as this is the practice of medicine. They've done way more HODs than you have. They know what has been most successful for them to recover their patients. So if you see something that's out of the specific algorithm, because medicine is not a cookbook. You can't go down the line and have the same ingredients every time. You've got to pay attention to your patient and know what's going on. So if they pull something out of the hat that you were like, why are we using that? Ask, because it's going to be a good learning point. They're going to have a reason for it, and they're going to be able to explain that to you. Bicarb used to be a huge medication that we would use, and it's no longer in the protocol. And when you've got a patient that's acidotic and you can't get their acidosis to correct by blowing off and hyperventilating them or other medications that you've given, You may need to use bicarb IV to change that acidosis, because I know for a fact that if their pH is too low, they won't respond to any medication. Their heart can't respond to it because it's too acidotic. It's almost like the temperature in hypothermia that he was describing. Until that body gets a certain temperature, it won't respond. So you're shooting yourself in the foot and wasting a lot of medication, as well as you've got tons of medicines in the body circulating by the time their temperature gets to that point, if you've already started running through those. You're probably not going to have any more of a rhythm than PEA anyways if they're hypothermic, is what my thought was. But still, don't be pushing those medications until their temperature is to a certain degree. And then also, if you see a preceptor do something that's off of that, ask questions, because you will learn. Standard of care, test purposes, know what's written down on these papers. For your boards, know what's written down on the standard of care protocol, not what's done in real life. And you're going to learn that when you go out on rotations. And we like everything to be black and white and written down, but the reality is, like you know, medicine is subjective and not everybody is the same, and your patients are not going to respond to the medications the same. You have to watch and learn. That's why it's important for you to know the physiology and know how these medications work and what the purpose of these medications are trying to do, so that you can see if it's working. Then it will become easier as far as knowing which medications are used for which arrhythmias, once you've gotten that understanding down. There's your H's and T's again. I can't stress that enough. And then they've got the pressors over the side. I've already mentioned that as well. So your IV bolus of fluids, normal saline is going to be your go-to in a code. And obviously maintaining your body temperature. So if you've got a hunter that came in cardiac arrest with their body temperature, you've got to get every vital is low, 98 or lower, then you're going to put that bear hugger on her as well. So think of everything again, because again, if your body temperature is too low, they're not going to respond to those medications. You're just spinning your wheels in the mud, not getting anywhere. So that's what it means by hypothermia, and that's one thing that sometimes we get to going through everything and we didn't think, oh, their body temperature isn't enough for them to respond to these medications. I've got to get them heated up, because that's not the first thing that comes to your mind when you're running your code. You're thinking intubate, airway, circulate, get the drugs in, not what's the temperature. Okay? So again, it's okay to slow down. 5 minutes is an eternity, and just remember that. That is where, even though I freak out on the inside, my mannerism of being calm keeps my team calm, keeps the family calm when they're in the room, and it gives them that sense that I'm fully in control, even though inside I may not be. So you're thinking, and you can learn that. I had more success with recovering patients in my code percentages, because everybody does it. You keep it in your head. What's my rate of success? How can I improve? You should do that. That's your own quality control, quality assurance. That's what we're here to do, is to keep people alive. When I slowed down, my rates of success went drastically up. So if I can teach you anything, that is huge. All right. So ischemia or infarction, acute coronary syndrome. We've had a whole lecture on that. No, we haven't. That's the second half of ER. So that will come after your first test. But, so biggest thing is looking at the EKG. Are they having STEMI? Are they having an in-STEMI? Are they having some other cardiac event that we're not sure why? So this is kind of your algorithm of your thought process, but obviously, anytime you've got somebody coming in with chest pain, as long as they don't have a blood viscosity, hemophilia, clotting disorder, you're automatically going to be looking at if their oxygen saturation is low enough, I'm giving them oxygen. We're going through the ONA without the M, right? Giving them nitro to have a chest pain. See, obviously nitro only if, what parameter are we going to look at, April?
Inferior, if it's an inferior.
If
And
it's
have
an
that
inferior,
blood
you
pressure.
don't use it, right? And then also your blood pressure, absolutely. So if your blood pressure is too low, do not give nitro. You've got to have perfusion, and if you drop that blood pressure even lower, then the way to correct that, you see that and you go, oh shit, so then what do you do? Because you did it anyways. What would you think to do first? If your blood pressure was low, your patient's blood pressure was low, you gave nitro, what?
Epinephrine.
Before vasopressor, because that's the next step if this first thing doesn't work.
Fluid.
Fluids. So it's the first thing to get blood pressure up, volume. Okay. Volume equals perfusion. If you don't have enough volume, you're not going to get the circulation going. Contraindication to that would be, though, somebody came in and they've got a history of congestive heart failure and their legs are 3+, pitting edema, oozing out. No, we're not going to use the fluid, we're going to go straight to the pressors. Okay? Again, you're treating that patient, not just going through the cookbook list. This is where your application of medicine really comes in. All right. Aspirin is 160, which is what? If you're given 160, that's 2 baby aspirins because they're 80 milligrams apiece. And they're chewable. They're chewable, that's the best way to do it because it gets into their bloodstream faster. It's almost like doing the sublingual nitro. That is preferred over the 325 milligram tablet that takes longer to dissolve. But if your patient's not conscious, or if you're worried about them aspirating or choking, what are you going to do then? Usually they're conscious because you're going to intubate, but you could do, if you hadn't given them an aspirin or they hadn't taken it at home or had it by the ambulance crew, most of the time it's already done. If all of that is a fail, no, you could do a suppository. But very rarely, I've never done that because I've never had to. My patients have usually either already had it or they're conscious. Nitro, they've got a spray as well, so if the patient's mouth is really, really dry, and sometimes you can give them a sublingual, and you ask them within that 2 minutes time period, 2 to 5 minutes, has your chest pain been relieved? Sometimes they'll go, no, and they'll stick out their tongue and the tablet will still be there because their mouth was so dry there was not enough saliva to dissolve that. So that's where your spray comes in handy. Okay. Obviously you would take that one out and do the spray. And then they've also got the gel. So if the patient's completely unconscious, you can do the nitro gel or nitro drip IV would be even better. All right. And then your labs. So obviously, yes, I'm sorry.
How would you do the oxygen? So, I mean, just walking through like a cannula, mask.
Oh, I see. I'm sorry.
All that, and then like what you would set it on. Because people say that stuff, but poem was a long time ago.
Right, right. So nasal cannula is for somebody that is stable. Their saturations are just a little lower than normal. They've got a chronic COPD or an asthma condition. Those are the ones that you're going to do. They're awake, alert, talking to you. That's where your nasal cannula comes in. If they're in any type of distress, which is always documented as part of your vial, I was so happy when, I think it was Scott Airway that had mentioned it. So your blood pressure, temperature, height and weight obviously is not going to be done in the ER, but you're asking those questions to the family, if not to the patient, for BMI matters. And blood pressure, obviously, and those are continuously monitored things. Temperature, don't forget your temperature. A lot of people do, just disregard that. That's your oxygen saturation, again. So if your oxygen saturation is below 94, is when you will start being more aggressive. So 94, you've got your non-rebreather masks, you've got your mask that has, a non-rebreather is essentially a mask that's hooked up to the oxygen that has a bag, but the bag doesn't, it inflates, but it doesn't push air back into them. That's what that's called. And that's just so that they're not retaining CO2. If you are having to blow off CO2, that's when you're doing the ambu bag, which is the full code thing that you would go on the ET2. You can use an ambu bag with just a mask though, just like when you're pre-oxygenating them prior to intubating. You're going to learn that with rapid sequence intubation. There's an algorithm for you on that, okay? So you'll pre-oxygenate them because you know that once you're done and you take the bag away, you've got just a short amount of time to get that tube done. Because their oxygen saturation starts to plummet. Okay? But you can, even with that, you can use a bag without having to do it. If they're awake and they're saturating enough, you can just have it to the side and have it over and ready. And it all depends on the severity of their stability. If you feel like you're on the verge because you see that monitor and you've learned that this rhythm leads to this rhythm leads to this rhythm, which usually causes them to go out, or you see a rhythm and you're like, I don't know how this patient's still conscious, you better be ready to start, because they could go out at any time as far as intubating. Okay. So you are also going to get a full lecture on that after the first test, so let's just start that right now on mechanical ventilation. It is a scary thing and one of the hardest things to kind of get straight in your head when you're starting out, but it's really, most of the time you're going to either use that bag or non-rebreather mask. Okay. Nasal cannula, just for if they're awake, stable. All right. Here is your algorithm for your EKG interpretation. You should know this from cardiology. I'm not going to go over this in detail. It's just given to you because that's another sheet on that card and I want to give her access to it. Read through that. Come to me tomorrow if there's anything that doesn't make any sense to you. Not tomorrow, you won't be here. Email me. And I will email and answer back to the class. Okay? Everybody has access if there's something that's confusing or not making sense, okay? I'll see you on Saturday, huh? All right. Bradycardia. Obviously, your rhythm rate has to be less than 50. And this is with a pulse, because Brady without a pulse is what? Pulseless electrical activity. Okay. You guys haven't had these big ones. I'm sorry, I'm talking to you like you do. Have them already down. So, bradycardia with a pulse, if you don't act upon it, and it continues to deteriorate and slow down, then it will lead to PEA and then to asystole. So that's the succession of that rhythm. Bradycardia with a pulse that is staying stable and not really continuing to drop, again, you're just monitoring them. You're giving them supportive measures and you're trying to figure out what caused it. Most of the time, it's a new medication. They just went up on their beta blocker or their calcium channel blocker or combination hook, and it's blocked that rate too much and drops them too low. This is why anytime you've got a patient that comes in and had a syncopal episode, you get a rhythm, because they may still be in Brady, and they may have passed out because they've gotten too low, got hypoxic, or have a combination of bradycardia and hypotension. All right, again, airways. Airway, oxygen, making sure you're watching the monitor. Always having IV access, 2 large bore IVs. Okay, if you've got a little old lady that comes in with a syncopal episode, and she's Brady, and she's got frail vasculature, you're not going to have to put a central line in here. If you can get one good IV and then you can get a smaller peripheral IV, that is probably still going to be sufficient. Unless she has also a history of cardiac arrest or some other cardiac problem going on. But don't just jump into a central line because you can't get 2 large IV bore catheters in, angiograms, whatever you want to call them. I just say 2 large bore IVs. Bam. And everybody knows that large bore means 18. I'm not really going to go bigger than that. You never put a 16 in somebody. And you shouldn't put a 20 in. So it's 18. 18 or 18 or 18. All right. Persistent Brady, the causes, know these again. So altered mental status, we've had a whole lecture on that. So go through your acronym. What's the acronym have you guys been studying that could cause AMS? I know, you're like muddy pile cats, whatever. Pile cats, and he's changed that through the years, because one year there was like a doctor with like DR in there, and so now I'm like, what the hell is it? But whatever he gave you and whatever is on your notes, and it is in the transcript that I just sent you today, know that. That's one of the acronyms that you're going to utilize during ACLS. So see how that helps, so that you can think of all the possible reasons why they've got an altered mental status. What's the most common cause of an altered mental status? Yes, and in the ER though, glucose. Make sure you're checking your glucose, low glucose. So that's the first thing you should think of. Get me a glucose. If that's normal, then you're thinking of the other bad things. Obviously, if they smell like alcohol, there's going to be other reasons that are all going to be higher, but that's where your differential comes in again. What's causing their altered mental status? They overdose. What sex is the patient? What age group is the patient? What's their past medical history? What medications are they on? What's their living status? Are they homeless? Do they have a lot of tattoos? Do they have track marks? All of that. You're checking all of that. That's your primary survey on an ER patient that's altered mental status, unconscious. Signs of shock. Does that give you ideas immediately from that, or do you guys feel like we need to cover that a little bit more? What's your first sign of shock? What's your 3 different types of shock? This is way back. Cardiogenic, distributive,
Septic.
that is distributive.
Hypovolemic. Oh, sorry. Hypovolemic.
Hypovolemic, which, yes. So, cardiogenic, neurogenic, hypovolemic. Those are your three. Oh, and distribute, there's four, sorry. So know those, know what the causes are. So that's when it says signs of shock, that's what you're going to be looking at. Their vitals. Are they febrile? Are they hypotensive or hypertensive? What's their heart rate? Their heart rate and their blood pressure is going to be the first sign of sepsis. BP being the number one that you're going to watch for. And the whole past medical history, what's going on with that patient. Cardiogenic is going to be the easiest to diagnose because the monitor is going to tell you. And their blood pressure, they're going to be hypoperfused. You're going to be needing pressors. It's the main treatment for cardiogenic shock. Getting that rhythm into a normal rhythm and getting them normalized with a perfusion. So the most important reason that we give pressors to increase your blood pressure. What's the most important reason we do that?
Perfusion.
Perfusion of what? Organs, tissue. Because if there's no perfusion, there's no oxygen, you start having cell death of whatever tissue or organ that is. That. Okay? You guys have this. You got it. All right. Ischemic chest discomfort obviously is going to lead you. And then acute heart failure, listening to their lungs. If they're fulminantly in failure, you're going to hear. It's going to sound like somebody is like blowing bubbles in their milk. Or a wet cough. Everybody knows what that sounds like. You've heard it. Sometimes you don't even need a stethoscope. You hear that wet cough, and you see their lower extremities blown up, and you're like, okay, how long have you had congestive heart failure? They're going to know. What's your ejection fraction? Those are the questions you're going to start already on. When's the last time you had your echo? Have you had a heart attack recently? So that you know what the status of their heart is. All right. Your medications for Brady. Atropine is number one. You give the first dose, and then you can repeat it in 3 to 5 minutes if no response. And then know the maximum. So everything that's in that green box you need to know for your Brady algorithm. Then once you've gone through all of that, and it's been unsuccessful, then you go to the next box. Okay. So this is how I learned it. Brady, the A, and instead of spelling it with a Y, I spelled it with an E. And so my atropine was first, and I maxed that out, and then I went to epinephrine. It says transcutaneous pacing or dopamine or epinephrine. Epinephrine was the most successful, so I just changed it in my head, and that's how I know it always. And it hasn't changed. This is one of them that has not changed. So, know those doses, know those drugs. Change the spelling of Brady, and you've got your answer in your word, okay? That's how I learn, and it may be cheating or whatever you want to call it, but when I'm stressed out and thinking of everything else, it makes it easy. There's no reason not to do that, and you guys should think of ways to do that. All right. And then obviously you're going to be having cardiology on them. Your next one, tachy. So the most important thing when you look at the monitor and their tachycardia, what's the first thing that you're going to ask? Looks like we have tachycardia on the monitor. Our patient is unconscious.
How long have they been unconscious?
Do they have a pulse? You need to know, is it intact with or without a pulse? Because that changes the algorithm. See, this is tachy with a pulse, and obviously, otherwise it's considered to be intact. Do I not have? I will have to add that algorithm. Oh, they're calling it, so VTAC, VFib is what they're calling cardiac arrest. So when you've got VTAC or VFib, you go to the cardiac arrest. I'm sorry, that confused me. We used to actually, our algorithm was called VTAC, VFib. Or it was actually called pulseless VTAC, VFib. That's what the name of our algorithm was. If you want to rename that, because nobody goes, oh, they're in cardiac arrest, we say, they're in VTAC, do have a pulse. Or they're in VFib, hardly ever you will have a pulse with VFib. Somebody last year, and it was an ER physician, said that they had a patient that had chronic VFib and they had a pulse, and I was like, I'm not ever going to believe that until I see that. And he said the same thing that he was there. So, anyway. All right, let's go back where we were. Sorry, didn't mean to jump off that. So, tachy again. You see tachy on the monitor, first thing, do I have a pulse? Because that makes a huge difference on which algorithm you're looking at. If they're unconscious, they can still have a pulse if they're unconscious. So make sure that you're checking a pulse. That's way back to basics again. You've got all of these machines and bells and whistles hooked up to them, but you still need to check for that pulse. And when you do your medications, when you're circulating with your chest compressions, stop. Every 3 to 5 minutes, whatever your protocol says, check the rhythm. And you're checking it. Okay, resume CPR, about that long, because I see no response. Okay, so not even a full minute. You don't want to be off of the chest for a full minute. It takes maybe 30 seconds or less to assess whether or not they're responding. All right. Tachy with the pulse, the biggest difference is cardioversion, not shock. Okay? And that's how you're going to name it when you're having the order given verbally to your team. I've got VTAC with a pulse. We're going to cardiovert. Make sure that machine is set up for either synchronized or unsynchronized cardioversion, not defibrillation, because there's 2 different settings on the machine. That's the first thing that you're going to say. Okay? Now, if they go from VTAC with a pulse into VFib, you got to switch back over and then start with that algorithm. Okay? Anytime you're in an algorithm and anywhere and that monitor rhythm changes, you're ditching this one and going to whatever that new rhythm is. Okay? Those are kind of important things to know that we always forget to tell you. And then when you're like, oh shit, well, I didn't. I remember as a student, that was one of my thoughts. Crap, I knew what to do next, and now I don't know what to do. So you just have to change the page. Go to a different algorithm. Again, with tachy and the pulse, your Qrs complex is extremely important. Is my Qrs complex wide or is it narrow? Because that can be a matter of life or death when giving wrong medication. What's the one thing that we're worried about with a widened QRS? Right, which could cause them to go into VTAC, which they would run into that. But what's the most common cardiac issue that causes a QRS? No. WPW is what you need to be thinking. So look for that delta wave, and I can guarantee you as a student, it's going to be harder than hell on a monitor to see it. So if you've got a patient and your provider is saying, but what's your patient going to be typically looking like? Not as far as their status and appearance, but what sex are they going to be more than likely? What age group are they going to be?
15 to 20.
20s. maybe even teens, 20s, 30s. Or they're gonna tell you, I have WPW, and you're like, okay, great. Yay! Thank you for that information, because they know that's important. So those are the things, when we say look at your patient, that we're talking about, not just, do they look pallor, diaphoretic, and gray, and they're fixing to croak on you, because that is an ominous ACS appearance. Acute coronary syndrome, probably more likely an MI. If I could bet money on it and win a lot of money, I would probably too young bid just by looking at a patient and going, this is probably what her monitor is going to look like. And you'll get to where you're at that point if you do emergency medicine. But again, know what age group, what sex is most common for these conditions, and so that when you have that patient that's on the bed and you see that widened QRS, that's the first thing you need to be thinking. Or even that patient on the bed having a cardiac event, I need to rule out WPW so that I know that I'm not going to give them the wrong medication and throw them into VTAC, VFib, and cardiac arrest that you iatrogenically caused by the medication that you gave. Okay? Scary stuff, huh? But again, your team is going to be there. When I called out an order, and still, it's been a while since I've been in the ER, so if I go back, I'm going to be going, okay, the next thing on my protocol that I'm thinking is going to be adenosine at point, I don't even know off the top of my head, it's so long. Yeah, don't even give it up there.
6 milligrams?
0.6? Yeah, I was thinking 0.3, but then there's a maximum of 3, I think. Okay, so 0.6, and then you say, you know, is everybody in agreement, or you say it out loud before you give the order to give it. That way you're talking it through, and that minimizes your medical errors. I don't care if you have the ego that you don't want to look stupid in front of your team. I'd rather look stupid and my patient still be alive. Everybody agrees with that, right? Mm-hmm. And again, your staff is going to respect you for that, because you're going to have that team collaborative effort and say, dang, I really suck, I'm off my game today, or I will get better at this, because when you're a new student, you're going to not know all of that. Some places had it on the wall, which was awesome as a student. I'm like, thank you. But they're going to know it, and they're going to give you that feedback. And the next time you have a code, you're probably going to leave that situation and go study it, and you're going to learn from it, as well as the certain situation is going to be like a movie in your memory. And you're going to say, this is what their monitor looked like, this is what the patient's appearance looked like, this is what their vitals looked like, this is what we did, this is what I saw the monitor did. It's going to be recorded, and it's going to be amazing and freak you out. You will have that in your memory, regardless if you wanted to or not. And you're going to know what to do. So, that's amazing. All right. So, yeah, 6 milligram rapid IV push. So, the nurses will already know anytime you have 2 large bore IVs and you've got a cardiac event or running a code, they will, one of those will have a Y cannula on that PEP block. And the reason is because you're going to plug in whatever drug you're giving, and then you're going to plug in the flush. And you're going to push one and flush it immediately, and that's what it's called. Because again, you want that medication to get in as fast as possible, but you also want to clear that line out of there. You don't have to order that, they will know that. That again is you talking to your team. If you don't ever see that, which I doubt you'll run across, but if you don't, that's also a good time to kind of study the scenario. And how can I do quality improvement and help my team? Because that's going to make you a better asset for that team, and your supervising physician is going to love you for it. You're going to have longevity at that job if you're looking at all those things. Anytime we did trauma, we certainly were not a trauma facility. We had the trauma team from Wesley fly down every quarter and give us reports. This is what you did right. kudos on that. You always start with a positive. And then these are the areas you could improve in, not that you dumb idiots did this wrong. So that's how you could do with your team as well after a code. It's called debriefing. That helps everybody to cope, especially if you've got a loss, and improve so that it doesn't happen again. Because in medicine, you're going to lose patients. And the only thing you can do is improve on that. Hey.
Take your time. I know it will not go for 2 hours.
Okay.
So I'm just going to set my stuff down. I'll be back.
All right. So tacking with the pulse, the medications, again, you're going to be with the pulse. If you need to cardiovert, it's cardioversion, and it is synchronized. Make sure the machine is set to that. Know your amperage on your joules of what that is set at, what do you start with, and what do you go to next. And again, it depends on if the rhythm of the Qrs complex is narrow or wide. The wide irregular tachy with a pulse is treated pretty much like BTAC because they're getting ready to go into BTAC or BFib. That's why it says defibrillation dose, do not synchronize. So again, once you kind of put those in chronological order of what rhythm leads to what, it helps you to know how to treat it. Your medications for this algorithm, again, adenosine, amiodarone, and so on. Whatever medication slowed them down and brought them back to a regular rate, again, will be your maintenance dose drip that they go to the ICU on, or that they get on the helicopter with to keep flying them out. All right, the last thing that we're going to go over is stroke. So this is your stroke protocol. This is the Cincinnati pre-hospitalization stroke scale, which is the overall standard of care now. This is what I was talking about with the FAST, these are pictures. So every time I'm seeing that man and that woman, they should have a name because it's the same picture every year. So facial droop, arm drift, speech, and the T is time. Don't forget your time. I don't know why they didn't put it up really big, but time is extremely important. Shows you normal, abnormal, what you have them say when they're talking, and that's standard. Don't feel silly that everybody says the same thing. Easy to remember. And then here are your, this is the algorithm of what to do while you're getting the consult and the approval for TPA if you're going to push the blood, the clot cluster, or if they're going to be shipped to a stroke center. Make sure also that you make that phone call immediately. Time again is of the essence. So over on the left-hand column of the actual slide, in the middle, kind of past the, right next to the red, is your clock. So that's what to do in those time periods. 3 hours, within 3 hours of the onset of symptoms is the key number for you to know. If they hit your door and they're already past that 3 hours, you're not going to be doing TPA. You're going to stabilize them, give them oxygen, make sure that their vitals are appropriate. If they're hypotensive, you're getting them on fluids, pressors if needed, and then shipping them to the stroke center if you're not already in a stroke center facility. Even in the city, there is specific stroke centers. So Integris Baptist is a stroke center here. So regardless of where they're at in the city, where it starts, that's where they end up. Yes.
Are there any instances when that 3 hour can be altered? Yeah, I thought I remember them being pushed back to like 4.5 at the latest in some scenarios.
Because FDA is 3 hours, but they use it up to 4.5.
But like they'll go to 4.5.
Okay.
The FDA
So
approval is
you won't
3.
have to worry about that for test purposes, and in real life, consult the neurologist.
Yeah, okay.
Let them make that decision. I don't ever, with hard decisions like that, try and do it on my own. It's not worth the stress. It's certainly not worth the liability. You've got more than one provider consulting on that patient's scenario, and you're agreeing, so it's a collaboration. Big decisions like that, I mean, do you think that tumor boards, the oncologist, surgeon makes the ultimate decision on what to do? It's a whole lot of people getting together. So again, don't feel bad about talking to your colleagues. Make that a norm. Be professional about it. Let them know what you know. Let them know what you do not know, and ask for help. They will respect you. I mean, that is the fastest way to gain respect. And you'll learn fast too, because they will give you information. So again, when it's to a tough question like that, you're getting the specialist on the phone. When you're also doing things like this, I know rule-wise, I needed to report it to my supervising physician, but he sure as heck wasn't the first one I called unless I needed him there helping me. I was calling the specialist that knew all the answers first so that I could get the transfer documentation, and that already started, and the team in the air flying by the time, because I could be completely done, the patient's gone before I even called my supervisor. But you still need to let your supervisor know when there's situations like that going on. And you can always have, again, another staff member call Dr. Stewart, let him know what's going on. That's all you can say. That's all I did, you know. And most of the time, his answer was, "You got this. I'm 3 hours out. If you need me, call me again." Or, "You got this. I'm at home watching TV. I'm not really worried about it as far as knowing that you're capable. If you need me, call me." So you're going to run into that if you do rural. All right. So ABCs, obviously, and checking their glucose again, because somebody that has a low glucose could present with slurred speech, altered mental status, and it could give them ataxic gait and some of the other symptoms. So it acts like it looks like a stroke. Don't make that mistake. Make sure that every patient that looks like a stroke that you're checking that glucose. Finger sticks real quick. You do it in the clinic all the time. All right. And then CT. So this is just an algorithm that helps you to differentiate and know what you're going to do with a hemorrhagic versus a non-hemorrhagic stroke, as well as what you're going to be looking for. And you may not be doing it. They may be doing it at the stroke center. If you're in the middle of nowhere and they are a good candidate, you may be pushing the TBA. I don't know how many people I pushed TBA on, but it was several, because when this drug very first came out, we were giving it to a lot of stroke patients immediately, before the drug time. They kind of backed down a little bit. That's why you need to get your neurologist on the phone immediately, because if they want to do a different type of intervention or have better means or suggestions, you let them make that call as well. I've never pushed TPA without a specialist telling me to do so. So again, I didn't make that decision. I knew it needed to be made because of what was going on with the patient in this situation, and I knew that time was of the essence, but I didn't make that final decision, and I documented it that way. It's a collaborative effort. He didn't make that final decision because he would have had no idea if I didn't present it to him. So you are being a good provider, but again, you're not making that ultimate decision. So don't stress too much about that. All right. These are the ones that I said are FYI, the last three. So absolutely don't look at these until later. Because it's, even on your H's and T's, there's a few extra ones that they have to think of as anesthesia, and I don't want you to get confused. So do not look at those until after your test on Saturday, and you may not even want to look at it until after you take your boards. But I've given it to you because I stumbled upon it and I was like, ooh, I would have liked to have known that when I was doing ER. Because it would have helped me to understand a little bit more on